Okay, we're gonna try to get through a majority of this lab sheet as we can today. If not, we'll have time to catch up to where we're supposed to be. So we're gonna start with our special tests. The special tests are essential. You want to do each of these special tests before you do any type of mobilization technique in the cervical spine. That includes subcranial and mid-cervical spine. When your patient comes to you with cervical problems, these are special tests that you want to screen. All right, especially if your patient reports a history of trauma, like a fall from a ladder, motor vehicle accident, any type of head injury from sports, maybe like football, basketball, baseball, whatever the case may be. You want to screen these tests before you do anything in the cervical spine, all right? Before you do any type of mobilization. And they are quick screens to assess for various reasons. So first we're gonna go to page 372. So go to page 372. Explains the sharp purser test, and this is the modified version of the sharp purser test. So the sharp purser test is going to be used to detect atlantoaxial instability. So when might a person have atlantoaxial instability? Again, after some sort of trauma. And so if your patient comes in and reports any type of trauma, whether it's a fall, whether it's a motor vehicle accident, whether it's a sports related accident, you want to do the modified sharp purser test before you do any type of mobilization technique. In addition to that, we are direct access providers now in most states. So a patient can have a traumatic event and come directly to us as physical therapists. So we need to know what we need to do in order to rule in or rule out red flags. So this is one of them. So this is to detect atlantoaxial instability. So, and the rest of it you can read through as we go through it. I will need a volunteer. Come on, Kendall. Okay, great. So now I have Kendall. So what am I going to do? All right. I like to use my dominant hand to stabilize the C2, the axis. So I'm going to take my weld space. I'm going to take my weld space and come around her. And I'm palpating. So right now I'm at a simple condyles. Move right here. That's the atlas. If I drop right here, I know I'm on her axis. You feel that? So I'm on C2. My web space is stabilizing C2 so that C2 doesn't move. Okay? I'm gonna come around with my left arm and hand and get right here. Now, what I'm gonna do with my left arm is impart a posterior translation. All right? And what I'm looking for and what I'm feeling for is excessive movement. So with Kendall, so slightly flex just for me, slightly. There we go, good. Good job. I can feel it even better with her slightly flex, according to the textbook. And so now, her atlantoaxial articulation is stable to me. I was looking for excessive translation. Excessive translation typically is going to feel an empty infield. You may not be able to reach the infield or some type of abnormal infield. What I should have felt was a firm infield. I did feel that. Did you feel like it was that? So I get feedback from my patients too, as well, when I implement and perform special tests. So she didn't feel any type of excessive movement. Did you have any symptoms with that? But the main one is excessive movement, excessive translation posteriorly, which could indicate atlantoaxial instability. Now, you could also get atlantoaxial instability if your patient has a odontoid fracture. So that's why you want to do these special tests and rule them out. If a patient comes to you reporting any type of trauma, you want to do this. So this is the modified Sharp-Purser test. All right, I could have easily done it on the other side as well, but I wanted my dominant hand to stabilize C2. All right, being the axis, right? And so moving CO, C1, moving those posteriorly on C2.
You may also feel a clump when you release, when you let off. If they clump back, that can also be a sign that there's some of that. And think about symptoms too. So if your patient has some craniocervical instability, okay, and maybe they're riding a little bit forward and they're complaining of some symptoms like our peers taught us about probably in the first part of what they did today with the craniocervical instability, right? Maybe they're having some nausea, some headaches, some things that are nystagmus, some things that are suggestive of that. And when you bring them back in that position and it gets better, so you're kind of looking also how that changes their symptoms. Okay, if they have symptoms and that seems to even give them some relief, that can also be suggestive of some instability. So you want to make note of that. Talk to your patient about how they're feeling as you're doing this too.
And so the next one on page 374, and then after those two, I'm gonna let you all practice these two, and then we'll come back and do the other two. But the alar ligament stretch test, again, if you have a patient who's come with neck pain, and they have neck pain from a traumatic event, from a traumatic episode, you must do these, especially if they come in direct access and they haven't had any imaging, no x-rays, no MRIs. You can catch something serious if you do these special tests. All right, so the next one, I can leave Kendall like this, or I can have her supine. I'm gonna leave her like this. I can also do the same thing supine. All right, it's in the book showing it supine. So again, I'm stabilizing which vertebrae? C2. Again, I'm stabilizing C2. So I come back in. Now I'm gonna use, instead of using my web space to stabilize it, I'm actually gonna use my thumb and my index finger to stabilize it, okay? So I'm gonna come in like so. You could come and look back here too. So mastoids, I know right now I'm on the atlas. I'll drop right down right here. Now I'm stabilizing the axis. I'm stabilizing C2. So now, what am I going to do? So I'm gonna keep her in neutral, right? So I'm gonna do a subtle side bending. So I'm stabilizing C2. And so, right there, that's good. So I should not be able to side bend further than this. See, right there is blocked. I shouldn't be able to stabilize further, side bend further than this. You feel that, Kendall? Mm-hmm. If I go further and overstress it, it's gonna be painful for her. It's gonna create pain. But I shouldn't be able to go further than that. If I do go further than that, what could that indicate? Alar ligament laxity or tear of the alar ligament, okay? So, right now, I'm not concerned about the specificity of which ligament. I just know that something is going wrong if I get excessive side bending to either side. Now, based on the orientation of the alar ligament, when we can look this up on the computer, because it runs in different diagonals. So I want to bring her into slight flexion as well. So I want to do the test with her in slight flexion. So I'm going to side bend. That's it. That's as far as she can go, right there. You feel that, Kendall? If I go any further, I'm forcing it, because I'm stabilizing the axis. This is it right here. This is as far as she can go. But what if she were to go further than that? What if she just was to keep going? Yeah, it could indicate a tear. Now I'm gonna put her in slight backward bending and do the same thing. So, Kendall, do you feel that I got C2 blocked out?
Yes.
Can you feel it? Your patient should be able to feel it. She can feel that I have C2 stabilized, so it's not gonna move. All right. Same thing. Can you feel when I come to the end? All right. So what I'm looking for is excessive side bending with that to indicate, and if she excessively goes more side bending than the other side, then that could indicate alar ligament tear. So I'm comparing both sides. So you got to compare both sides, but you got to get in on C2. So you come in, you can locate the mastoid processes. So right now my hands are on her mastoid processes. If I drop down finger, probably drop down about finger width, okay, I'm right there on the atlas. And then drop down another finger width or half width, I'm right here on the axis, okay? The TPs and processes of the atlas, okay? What are we gonna do different this time with the anterior shear test? Well, it's telling you, but you just move it anteriorly. It's pretty much the opposite. It's pretty much the opposite of the sharp person test. So I can actually,
Come on, Ken.
come on, Kendall. Kendall got that hairstyle going on.
Sorry.
She got it going. Okay, so I want to assess the transverse ligament. What am I going to do? So I'm going to bring my hands in, and this may not, you can read through the book. This may not be verbatim from the book, but I'm doing what it says in the book. So I'm bringing my hand and I'm cupping, and my index finger, I'm going to bring my index finger, okay. Ultimately, what I want to do, I want to move C1 on C2, right? I want to translate those anteriorly. So my index finger, I'm coming off of mastoid processes. So you feel that? Mastoid. I'm coming right here, coming around, and my index fingers are on the atlas, okay? And so I'm gonna translate her anteriorly like so. So you see what I'm doing? I'm translating those anteriorly on C1 on C2. Is that it? That occur? Yeah. And so I'm looking for, again, I'm assessing for empty infield, but this is firm. It feels good. That's it right there. But it's a firm infield, okay? And coming back down. So this informs me that her transverse ligament is intact. Now, in addition to that, I'm looking for some other things too. Because if her transverse ligament is not intact and I translate her, if she goes excessively anteriorly, this could cause dizziness, headaches. Patient can report hearing issues, visual issues, but patient could have report of feeling lightheaded. So there could be different reports that the patient can give you that can also yield a positive test. So read those reports, Kira, from the, what does it say in the text? What could the patient report?
They could feel an increase in motion or empty, I don't know. Hold on.
Empty infield?
Yep.
Yep, I said that one.
Reproduction of symptoms of instability and production of lateral nystagmus and nausea.
Okay, so good. So make sure you know those. So a person can report nausea, reports of instability, and so we want to keep an eye on those things as well, and the stigmas. That's an important one as well.
So have them keep their eyes open while they're doing it so you can visualize. If they're closing their eyes, ask them to open their eyes so you can see if there's nystagmus.
Yes. So make sure that they open their eyes on this particular one. Okay. But with Kendall, I would deem Kendall, my clinical impression would be that that test is negative. And so if I run through all of these 4 tests, and they don't take long in the clinic, and when I run through these 4, if this patient come in with a problem, say this patient came in with trauma to the cervical spine, all right, this person fell off of a ladder. Before I do anything with this person, I would do these special tests, right? If I rule them out and then I see that this person just has muscles that are stowed up, that are guarded, and just have some hypomobility issues, then if all of these tests are negative, then I can safely proceed with manual therapy, with maybe some soft tissue work, followed by some gentle joint work, and grade myself as I do that. You see? But if any of those tests are positive, then I'm referring back out. You know, this person needs to go back to primary care, or if they haven't had imaging done, they need to have some imaging done for their cervical spine before we proceed with doing anything, because we want to be cautious in what we do. Okay, so that's the anterior shear test, transverse ligament stress test. And then the last one is rotation extension vertebral artery test. That's on page 388.
And while he's looking at that one, so if you understand with that first test, sharp pursor, right, you were pushing occiput and atlas posterior, right? So if a person had transverse ligament instability, they would probably be right and forward, right, which would produce symptoms. And when you push them posterior, it relieves it. Versus in this test, the anterior shear test, you're taking the occiput and C1 atlas and you're pulling them anterior, right, which will produce symptoms. So do you understand why that test might provoke symptoms versus sharp pursor might relieve symptoms? Make that connection?
Okay. So the rotation extension vertebral artery test, we mostly know this as just the vertebral artery test. This is in your special textbook as well. So rotation and extension, it just tells you what to do. Okay. So now I'm gonna remove this pillow. Oh, I forgot to put my wedge under my patient to make my patient more comfortable. Lift your legs up, patient. There you go. Have that, patient. Okay. All right. So now I'm gonna come right here. I'm gonna remove the pillow. All right. I'm gonna rotate her to the right, and I'm gonna extend her. I want you to look at me. Hold that. Count to 10.
Out loud?
No, count to 21 by threes.
3, 6, 9, 12, 15, 18, 21.
Okay. No nystagmus, any lightheadedness, any nausea. Okay, so rotate left and extend. Count to 100 by twos, starting with 92.
92, 94, 96, 98, 100.
Okay, so any lightheadedness?
No, I don't know how to describe it. Maybe like slight dizziness.
Slight
but
dizziness.
Not anything crazy.
Okay. So not anything crazy, slight dizziness. So what we want to just make sure that the vertebral arteries are not compromised. So if she has any lightheadedness, dizziness, or nystagmus where the eyes are going beating side to side and she didn't have anything, this is another one where you want to ask them to keep the eyes open. So there's nothing alarming. The person could report dizziness because if you don't go into these positions, like she did, slight dizziness, but it's not alarming, that could be normal for most people who don't go into those head positions all the time, you know.
What if it's a positive test, but it's not because of a artery dysfunction, it's because of vestibular issue?
So-
Canal issue.
That's good. So it could be that as well. It could be a vestibular issue that could cause the dizziness, lightheadedness, or nausea. So then we had to do a differential diagnosis workup and maybe refer her out to like an ENT specialist to see if it could be something going on with her inner ear, if it's something vestibular. That's what I would probably do. Okay, or you could probably do a treatment trial, and do a treatment trial for like 6 visits and see if the patient improves. Maybe get on like some vestibular home exercises and see if that dizziness resolves. And if it does, then we can come back and say, okay, it was likely that dizziness was likely due to some type of vestibular issues. So it's the same thing when physicians, when people go and complain about pain, somebody say, oh, my hip is killing me, my hip is so painful. And the orthopedic doctor will say, where? Then they point the side of the hip, right? And they give them an injection, a corticosteroid injection. If the pain decreases when that doctor gives a corticosteroid injection, if the pain decreases and it helps the patient, and the patient benefits from it, then the surgeon or the orthopedic doctor will say, oh, okay, well, it most likely was some type of inflammatory process like bursitis or something like that. And the corticosteroid injection was beneficial. So same case here. If we have a suspicion, we can implement trial and then refer the patient out if we have to eventually. All right. So that's your anterior shear transverse ligament stress test and your rotation extension vertebral artery test. Make sure you have a strong command of those. Will you have to know those for your practical exam? Yes. Because I could ask you to perform any one of those, any one of you, okay, before you do anything in the neck. Okay, so perform this special test. Perform this special test. So make sure you have a strong command of those and know how to perform those. Make sure you know how they look visually. Sometimes just going, constantly looking at the picture will help you. Even with manual muscle testing, goniometry, all those type of things. So I didn't want to rush through this because this is important. This is foundational for examination and treatment. So we're gonna go through this one quickly. It's not gonna take long. So remember, we're gonna do our passive intervertebral motion testing as well at the subcranial spine. So it's a gentle motion, subcranial spine forward bending about 0 to 15 degrees. I want to limit the forward bending to the subcranial spine. So I'm not assessing the mid-cervical spine. I'm just assessing the subcranial spine. And again, I'm looking for, as I passively do that, I'm looking for any type of deviation. So if she deviates off to the right, I know that I have a restriction. If this is with forward nodding. If she deviates to the left, I know I have a restriction. So say I do this, I'm forward nodding her, and she deviates to the right. Where's the restriction? It's on the same side. It's going to be the right side is likely not posterior gliding. So the right side is probably lacking the posterior glide of the occipital condyle on the atlas on the right side. Okay, and she deviates to the left, that left side is not likely posterior gliding as it should. Okay, all right, now I can assess backwards nodding. So with backwards nodding, if she deviates to the right, then the problem is on the opposite side. All right, If she deviates to the left, the problem is likely on the right side. But I'm gonna go through this process and get a feel for her backwards nodding. Does everyone see this? And it'll be in video as well. So this is assessing backwards nodding passively with my hands. So you feel how far you're going, Ebony?
Mm-hmm.
Not a whole lot, is it?
No, sir.
But it's assessing subcranial spine. I'm not doing the mid-cervical, all right? Subcranial, all right? Then we have, so forward nodding, I can assess forward nodding, also forward nodding with rotation. So I'm not gonna rotate that far, about right here. Just get a feel subcranial. So she feels free. Why would I do it with forward nodding and backwards nodding? So I would assess forward nodding and backwards nodding with rotation because it could give me an idea of to where the problem could be. You see? So if the person is restricted with rotation with forward nodding, then what's required for forward nodding? Posterior glide, right? So that means if rotation is limited, posterior glide can be the problem on either side. It gives me a hint. All right, if I do it with them backwards nodded and I rotation is limited, then that could give me a hint to that, okay, maybe one of the sides is not anteriorly gliding like how they're supposed to. Does that make sense? Because the simple condyles have to glide anteriorly with backwards bending, and they have to glide posteriorly with forward bending. So I kind of assessed it with both. So now I can also do side bending rotation. So I can go side bend right, slight side bend with rotation right. Just to get a feel for that. Slight side bend left, rotation left. And I'm just keeping it at the subcranial spine and see how it feels. Okay, and so you just get a feel for those. And whatever you feel, you just jot it down. And you can come back to it and play around with our hypothesis that we went through. Remember, we went through the hypothesis in the previous class, and you can play around with that to kind of figure out what could be going on. All right, now, there's one, intro, we didn't have time to do this. So I have to do it now, since we're on this. Did you all learn how to assess subcranial rotation? The quality of it, of subcranial rotation. All right. So when we assess rotation subcranially at the AA, OA, AA, we have to lock out the mid-cervical spine. All right. How do we lock out the mid-cervical spine? Kentori said, I don't know. All right. So pay attention to this. Write these steps down. So to assess AA rotation to the left, I'm gonna start with this. To assess AA rotation to the left, I'm gonna take my patient and I'm incorporating just a slight flexion with this. So right now she's in neutral. I'm just gonna incorporate slight flexion with this. I'm gonna side bend her to the right. Okay, so she side bend to the right. When she side bend to the right, I'm locking out the mid-cervical spine. The mid-cervical spine is locked out, right? So now, when I rotate her to the left, I'm assessing subcranial spine rotation. So OAAA. So now, I gotta stay in this plane. I gotta be very careful not to come out of this. So I'm gonna go slowly and rotate her to the left.
This is your technique on page 395. That's described.
I'm just going slow to see how far I can get. This is about it right here. Because if I go any further, she's gonna come up out of the plane that I want her to come stay in. So you feel that, Ebony? That's about it. Okay. So I'm gonna compare both sides. That's a. Bring her back. I'm gonna test it again. I'm gonna come back. All right. So now, what did I do to block out the mid-cervical spine when testing OA rotation left?
Side bending and rotation.
Which way did I side bend her to? So I side bend her to the right to assess OA rotation where? To the left. All right. Now I want to assess OA rotation to the right. So what am I going to do to lock out the mid-cervical spine? Side bend her to the left. And I kind of bias her in a slight flexion. Side bend to the left. So she's side bent to the left, right? So now her mid-cervical spine is locked out. When I rotate her, it's assessing subcranial spine rotation. All right? The mid-cervical is locked out. I'm keeping her. I'm going slow. All right. I feel that's it right there. Okay. So she's about the same on both sides. Do you feel a difference? How do you feel? Because
I
sometimes
noticed on this side, I felt tightness going down my back right there. Just a little bit.
Okay, when I did this right here. Okay. All right. Okay. So now I know what has to occur, right? I know what has to occur. So when I get her into side bending to the left and I assess AA rotation to the right, what does the atlas has to be able to do? What does the atlas have to be able to do? The atlas has to be able to slide to the left. It has to be able to glide to the left with rotation right. When I assess rotation right, it has to be able to glide. When I assess when I assess rotation left, it has to be able to glide and slide to the right. So we know that, you know, if the person is lacking rotation, that could potentially be a problem at the AA. All right, that could potentially be a problem. Then we know what has to occur at OA, right? If I rotate to the right, so I get her right here, side being left, rotate right, what has to occur at OA? Right posterior glide and left anterior glide. So make sure you know that. Make sure you know what has to happen at OA and AA with rotation right, rotation left, all right? Because that, if the person is limited when you assess it, then those could likely be your problems. You treat them, you see if the patient improves, okay? But we're gonna give you techniques to treat them, all right? So this is good for you all to know going into the clinic, because you're gonna likely see a patient with this problem. And you come back to this, review this, you think you got a patient with this problem, you assess it, all right? Read your charts before the patient comes when you go to your clinics. So especially when you go outpatient ortho, most of the time, the front desk receptionist or staff is gonna have the referral, and you make sure you read through that. Sometimes doctors send a history, make sure you read through that before the patient comes. And so if they come in with cervical issues, you know, you can make sure you screen this. All right. Anything to add, Dr. McClure?
I think that's good. And then your technique here at 394 is real similar, except that instead of taking up all of the motion and side bending to lock out the mid-cervical spine, you can also lock out mid-cervical by taking them all the way into flexion and then removing rotation. Okay, so you've got a couple options there to really assess that subcranial rotation.
Mm-hmm.
Okay.